Hi, my name is Dr. Ed Shahady, and we're here at the Cardiometabolic Risk Summit in Las Vegas. And I'm here with Dr. James Underberg. He's from New York, Bellevue Hospital. He's a clinical lipidologist, also runs a lipid clinic, and I've heard him speak many times. He just gave a talk, which I got to hear a portion of it, which was outstanding. And he was talking about statin safety, intolerance. What's intolerance? Could you define that for us?
So, boy, you're asking the million-dollar question.
Yeah.
And I think the take-home lesson from the talk I just gave is that while we have some definitions, there really isn't a lot of harmony. You've got a lot of different people suggesting a lot of different things, and even the FDA has chosen not to define statin intolerance. So an accepted definition that people often use is failing 2 statins, one at the lowest starting dose. But in real-world medicine, that's not really useful for us and our patients. So what I tell people is whatever you can do to help that patient get on a statin is reasonable. And if you ultimately fail, then the patient is intolerant.
Right. Okay, let's talk about, the one I think we think of the most, that myalgia, muscle aches and pains. The research data, in studies, 1, 3, 5%, but in the real world, I think it's reported to be up to 20%. So how common is it? And how do I know they really have a myalgia related to the statin? How do I approach this as a clinician?
So that's a great question, and I'll tell you that you're absolutely right. If you look at clinical trials where people are blinded to what they're taking and pre-screened, so they're not at risk for myalgias or haven't had them, the rates are very low. If you look at observational data at the National Lipid Association, we actually mentioned about 10%, but you'll see it even higher in other observational data sets. And so I think that's where it gets a little confusing for people. Ultimately, what you want to know is what happens in real-world practice. And so, again, I think when we're thinking about patients that are statin intolerant, I think these higher numbers are probably more appropriate. Absolutely.
So if I do my due diligence and I think that it's really due to a statin, what's my move? Stop it completely? Another statin, wait a while, what's my strategy?
So again, we've made some proposals on what's reasonable. The first is, again, to try and understand whether it's from the statin at all or not. And you had asked me that question earlier and I didn't answer it, so I'll answer it now.
Okay, good.
Which is, I think, a good, careful history and physical. Make sure there are no secondary causes, hypothyroidism, underlying muscle disorders, etc. Make sure the patient doesn't have a history of joint-related issues or rheumatologic disease. Make sure that the statin use is temporally related to the symptoms. When it started, did the symptoms get worse? And then if you de-challenge the patient and you take it away, did the symptoms go away in a reasonable period of time? There's some really good data from some old studies suggesting that the majority of patients who get symptoms do it fairly quickly. So that if someone is going to develop symptoms, it will be soon. And if they're going to go away, it should happen pretty quickly. And so when we look for symptoms, are they tending to be bilateral as opposed to one-sided? In the upper or lower extremities, the large muscles, the upper arm, upper leg, those are the type of things we look for. So again, a bilateral presentation, appropriate muscle groups. Weakness is the other one that a lot of people often overlook. And you can't really evaluate weakness if you don't watch your patient walk into the office, sit down and stand up. And so these are all very important parts of making the decision.
Wait, you do any quick test to see if the muscles are weak, just like sitting up from a chair? Is that helpful?
We do that. I actually ask them to pull back, push forward. I look at muscle strength in the upper and lower extremities, especially if I suspect there may be a problem. Someone says to you that they get tired when they walk upstairs. We often think of shortness of breath and heart disease. But if they're on a statin, ask them, is it tiredness or are you having trouble walking? Is it fatigue? And so again, that's the key point of it. And then what do? Well, again, after you try taking it away and re-challenging, if you've established that it is the statin, then you can try another statin. And you can try as many as the patient will let you try. One good study shows that if you try every one, about 30% will ultimately get on a statin. These are people who have failed the statin, so it's a pre-selected group. But there are alternative methods of dosing, every other day, once a week in some of the longer-acting statins, or using low-dose statins with other medicines that lower cholesterol as a second line.
Like what do you suggest as a second
I
medication?
would probably use ezetimibe first, just because it's the only drug that has any data showing that when used in combination with a statin, it reduces CVD events. Bile acid sequestrants are non-systemic, but they have their own set of side effects, and some people don't tolerate them. Niacin, really a fourth-line lipid-lowering drug because of issues around its safety and tolerability, and no really good data about its reducing cardiovascular events as an add-on, or even in monotherapy medication for that reason. And so we start to look at some of the newer alternatives that are out there. And again, their PCSK9 inhibitors now are recommended for patients on optimal statin dose, both for ASCVD or familial hypercholesterolemia. But the FDA was very careful not to say statin intolerant. Well, I guess if your optimal statin dose is 0, you're statin intolerant. So it is a very gray area right now. I absolutely agree with you.
Well, what about some of the other issues, like some of my patients who complain of memory loss, and they stop the statin and memory's better? Is that real?
Well, it's very interesting. The National Lipid Association and other organizations have defined statin intolerance as either real or perceived. And so if you believe, as a practitioner, that statins don't do this, but if your patient does, then it's real. For that person, it's real. And the more you try to convince them other ways, the less likely they will trust you and come back to you. So we were very clear about that. Perceived is real when it comes to statin intolerance, because if someone won't take the drug, they won't. But there's fascinating data, just recently published actually, and presented at AHA this past year, showing that in patients who were diagnosed as statin intolerant and then pre-screened for placebo-based intolerance, up to 70% of them were able to remain on a statin at a low dose for about 70, 80 days. So again, what you and I think we know when it comes to statin intolerance
may not be true.
May not really behave that way in the real world. And so I think for each particular patient, it's an individualized approach. And there are some algorithms out there. There's an app you can download. But again, it's just guidance. And you really have to make what I call a shared set of decision processes with the physician or the provider and the patient.
So if they do complain of memory loss, can I use the same routine that you described with myositis, off of a re-challenge, change a statin, go to lower dose, seem reasonable?
Well, what we say generally is if someone complains of memory loss, and again, the FDA has called it mild cognitive abnormalities, it's not unreasonable to stop the statin, even though the blinded data doesn't support that statins do that. And what the NLA recommends is that if you stop the statin and their memory doesn't get better, they need to see a neurologist, because it's not from the statin. And I think that's reasonable and appropriate.
And dealing with an overpopulation.
Yes, and that's the problem. And again, when people report a problem, it's different from not knowing whether or not they're on the drug or not. You have to take that with a grain of salt, but it still impacts their decision about whether or not they're going to take the drug. And you know, we've all had patients in practice who come to us and swear that their ability to think or perform is impacted by a drug. It could be statins or other drugs. And as our old Surgeon General said, people won't take drugs that make them feel poorly. So luckily, we've got a lot of options. We've got 7 statins. We've got a bunch of traditional non-statin lowering meds. And we've got some new drugs that are available to us now. And I think it's just using them judiciously in the right patients that really is part of this algorithm.
Let's talk about AST and ALT. You know, initially when statins came out, you got to measure every 3 months. That's changed. Well, should I let that, you know, I have a patient that their AST and ALT probably elevated before I started, but goes up while I'm using it. Is that an indication to stop the statin or change the dose?
So again, if you look at the risk of fulminant hepatic failure in the general population, it's identical to that in the statin-treated population, which is why the FDA made the recommendation to check liver function tests at baseline to make sure someone doesn't have underlying liver disease, because statins are metabolized in the liver. But after that, don't do it unless you suspect liver damage. Well, what's that? Waiting until their eyeballs turn yellow or they start to have ascites? So realistically, patients still continue to get liver function testing done because of A, not knowing what liver disease might be, and B, because they're so used to checking this, and because it comes on panels, oftentimes it still gets done. I would tell you that if you look at data about people who increase their liver function tests on statins, the majority of them, if you repeat the labs 1 month later, go back to normal.
Right.
And so reactively stopping is probably over response.
Right.
And you probably don't need to do that. Look for other causes. Have they been drinking? Do they have fatty liver? There's one study in a post hoc analysis shows that statins actually improve fatty liver. There are some rare diseases that may actually make liver function tests get worse on statins. One called lysosomal acid lipase deficiency. So it's a way of diagnosing that condition.
Very rare, though, right?
Very rare. So I would tell you in general, look at liver function tests with a grain of salt. Statins are metabolized in the liver. There are going to be up and down, measurements.
Didn't the FDA change what used to be in the product label?
Yeah, they said,
then they said, now we don't have to do it.
They said, stop doing it. You don't need to do it.
Right.
And so, again, I think you're going to see a trend toward that down the road as payers try to limit laboratory testing that may not be indicated. And I think we probably do over-test liver function testing.
Don't you think that a lot of these people have fatty liver? Because maybe some of them are pre-diabetic metabolic syndrome.
It's the most common cause of abnormal liver function tests. And realistically, if you look at patients who get put on statins, many of them have cardiometabolic risk that can be associated with fatty liver and abnormal liver function tests. And so, again, fatty liver is not a reason to not put someone on a statin. And in fact, many people might say it is, because it means that person does have cardiometabolic risk. And again, I mentioned this one interesting study with the atorvastatin. It's a post hoc analysis showing that the patients with fatty liver not only were more likely to regress their liver function test on a statin, they were the ones who seemed to benefit most from the statin from a cardiovascular perspective. So it's almost a stress test as to who seems to benefit the most.
Yes.
So I think the key is if you find liver function abnormalities before starting a statin, try to understand why the person has a problem. If they have acute hepatitis C, probably not the right time to start it. If they have stable hepatitis C, probably perfectly fine.
Okay, very good. Well, thank you very much, Dr. Underberg. We appreciate your being here and doing this. I know you've got one more talk you're going to do, I believe.
I'm looking forward to it. Thank you
Excellent.
for having me.
Yes,
It's really
sir.
great.